Cool. So today we're going to talk about neonatology, hopefully in the allocated time. So I apologize if it seems like I'm speeding through things. Hopefully at this point, everybody has seen all of the content, and this is just a good kind of summary and refresher. But if there are any questions that come up throughout, just like turn your mic on or write in the chat or something, and I will do my best to see it. If not, hopefully the others, Ash and stuff, will alert me to it. Cool. So in terms of what we'll be covering today, we're going to go through APGAR, neonatal resus, prematurity, intrauterine growth restriction, and small for gestational age, and the difference between these two. We're not going to be going over respiratory distress. That'll be covered by one of the other lectures. And then we'll go over neonatal sepsis and also neonatal jaundice. So these are just some definitions. I'm not going to go through all of them, but just to kind of orient everybody to what we'll be covering today in terms of the neonate, this is referring to babies that are less than 28 days old. But more specifically, we'll be talking about the kind of early kind of 24 to 48 hours post-birth as the main time where we can see some complications arise. But I just thought this might be a good little point of reference to include for you guys as well. I think this was from a previous year's revision lectures. So in terms of APGAR, this is, as we know, one of the first indicators that we use to identify a well or unwell baby post-birth. So essentially we use it in order to identify newborns who need resuscitation. So routinely, we perform an APGAR at 1 minute and then again at 5 minutes. And depending on how well or unwell that baby is, if we see that the APGARs are less than 7 out of 10, then we continue to do subsequent measurements at 10 minutes, 15 minutes, and 20 minutes, as well as intervening as required. So just to go over the APGAR, it's a mnemonic. So first we look at appearance, how pink or pale and blue is the baby. We look at the pulse, whether the baby has a pulse above 100 or less than 100, or there's no pulse at all. The grimace is whether or not the baby cries and pulls away and kind of is not quite moving about, because that comes into our activity. And then we use R for respiration, but mainly that's about whether or not the baby's crying. So although if you add up all the total scores, it's 2 scores for each and there's 5, so it's a total out of 10. We very rarely, if ever, give a baby a score of 10, because there's usually the main area is that the baby's usually a little bit blue in some areas. So we never really give them 10 out of 10, but APGARs of 9 is very standard and very normal, which I'm sure everyone's heard. And if somebody's asked you to give the APGARs of a baby, saying that they're 9 is a pretty safe bet. So going on from that, we'll talk about neonatal resus. And unfortunately, there aren't any tricks in learning the resus. You just have to know this flow chart. But we'll go through a few questions and try and kind of reinforce the important points. And the questions that we'll go through are actually from previous exams. So this is a very good indicator of what you might be asked. And I'm sorry if people have seen my lectures before, because this is a repeat of some questions that we've been through, but hopefully that means that you have remembered them and you'll get them all correct. So in terms of going through this flow chart, the first 3 questions we want to ask when a baby is born, or even prior to the baby being born, if you're standing there as the Paeds team in a delivery, you want to know first off, okay, is this baby term? Or is this a premature baby? And then as soon as the baby comes out, are there signs of breathing, or are they crying? And if there's good tone. So if the baby comes out floppy and quiet, obviously that's bad. But if they're just they've got labored breathing and they're still a little bit floppy, that's also bad. So essentially for this first point, we want to make sure there's a yes, yes, yes. 3 yeses means we can go straight to the mum, and we essentially don't need any neonatal resus. If there is any question that is answered no in this first kind of screening tool, then we need to go on to do 3 things. So we usually pop them under the little solarium bed. I forgot what it's called. The little resus trolley where it's got the heater. So we want to maintain their temperature, get them warm. And usually what they'll do, you'll see they're actually pretty rough, and they'll like rub the baby pretty hard with a towel and blankets to try and stimulate them. And we'll also check to see that their airway is open. So if they've got things like meconium or any kind of fluid in their mouth, anything that they might have aspirated, you want to make sure that you've checked that as well. Then all of these things are what you want to do in the first minute. So then we want to check their heart rate. And if their heart rate is below 100, or if there's any signs of labored breathing, then we need to go on and do positive pressure ventilation. And we also want to start checking their oxygen sats. Usually they'll pop on an oxygen sat, which checks the heart rate as well. So that kind of usually happens all in one. But you do that within the first minute. And that you've received the baby and you've realized that there's something wrong. And if you find then that the heart rate is still below 100, then you need to go on to the next step. So if the heart rate is still below 100, then you need to ensure that the airway is open, make sure that you've got a good seal over with the positive pressure ventilation. You might consider changing the pressure that you're giving and increasing the amount of oxygen, and you can consider things like intubation, but that's pretty unlikely. Next, the next question that you might be asked is whether or not the heart rate has dropped further or is below 60 at any point. And if that's the case, things are pretty dire. And so we need to start chest compressions. And the important thing to remember with neonates is that the ratio is 3 chest compressions to 1 breath, and we use 100% oxygen. It may be like they may have already been intubated, but generally it's just with the little positive pressure ventilation mask that they're wearing. And if they are persistently below 100, then that's when we can consider giving things like adrenaline. But again, that happens very, very rarely. So that's pretty much the big main steps to remember. So let's go over a question now. A well-grown baby is born at 39 weeks with a von Toos delivery after a non-reassuring CTG during the second stage of labor. At delivery, he's blue, he's apneic, and he's floppy. So first off, let's think of these 3 questions. So are they term? Yes, they're 39 weeks, they're above 37 weeks, so we're happy with that. Are they breathing or crying? No, because they're apneic. And do they have good tone? No, they're floppy. So before we've even considered that they're floppy, we've got a no from the second question. And so we need to go on to our neonatal resus pathway. And the first step in that, if anyone would like to write in the chat or turn their mic on, it's the first step. Let me just get the chat up. Cool. Sorry, yes, we are. Maddie's made a good point that I should slow down a little bit. I'm just conscious of the time, but yes, everybody take the time to read the question. So the first step here is to warm, dry, and stimulate. So we just want to give the baby a little bit of a wake up and see if they can manage on their own before we intervene. So we've done that, and this same baby is still blue and still floppy, and their heart rate is 75. So if we think back to if we think back to the flow chart, the next point was whether or not the heart rate, we're checking on the heart rate, and if the heart rate is below 100, then we need to start the next step in our resuscitation pathway. So in this case, the heart rate is 75, which is bad. And so I've got a few people already trickling in with their answers, which is great. If you want to send them to me privately, that's probably a good idea so that people can have their own time to think through it if they're not as quick. So the correct answer in this case is to commence PPV and attach an oxygen SATS probe. So the answer is H, correct. Final question for this series is, at 1 minute later, the baby's heart rate is now 55. So again, thinking back to that flow chart, which you may or may not have cemented in your mind right now, but that's okay. You can go over it. So the heart rate has now dropped below 60, which was our next sign that things are going bad. And so holy shit balls, next step in the resus pathway is to go straight to some, I'll just wait actually so people can give me their answers. Yes, we're going to go with compressions. And the ratio of compressions that we're going to be doing for a neonate is 3 compressions to 1 breath with 100% oxygen. So as I said, these questions are directly from a previous exam. So this is exactly the kind of style that you can expect in your exam. Any more detail than that is really not required, in my opinion. Cool. So just in the interest of keeping on going, we're going to go over prematurity now. And so prematurity is something that affects 5 to 18% of births worldwide. And I've got a little table up here. It's not really important to remember these definitions specifically. The only thing to remember really is that the more premature a baby is, obviously the higher the risk of complications and poor outcomes as well. So a few things that I know people, including myself, get really stuck with is something like corrected age. So if a baby is born at 25 weeks, and instead of saying that they're now 3 weeks old, we would say that they are 28 weeks gestation or 28 weeks corrected age, just because it's really important for premature babies to know they still haven't done all of their growing. They haven't had the development of their lungs and various other things. So it's important to still keep a track of where they might be up to in their gestation to be able to check in and see whether they're meeting their goals. This is also important for things like the suckling reflex and their ability to be able to take a bottle or breastfeed, because that's something that doesn't develop until like I think 35 weeks or something around there. So knowing the baby's corrected age is really helpful in being able to monitor their progress. In terms of what we need to know for prematurity, knowing some risk factors. So really young mums and older mums are those two extremes are a risk factor for preterm birth. The ones I've highlighted in pink are12 the main ones to remember. Premature cervical changes, a short intergestational interview. So I believe anything less than like an 12 to 18 month period between pregnancies is actually a risk factor for premature birth in the subsequent pregnancy. And smoking, as we all know, is bad, as well as drugs and alcohol during pregnancy. For the baby, like fetal factors, anything that causes increased distension of the uterus. So if the baby's big, if there's polyhydramnios, or if there's twins, then that's a risk factor. Fetal compromise, or things that have caused the baby to be stressed, and a sign of that would be meconium, is also a risk factor for prematurity. And then placental issues as well. And sometimes it's just iatrogenic. We know that there's issues with mum or issues with baby, and so we go in early and we decide to deliver the baby premature because we believe that that is safer than going longer with the pregnancy. So some of the main complications of prematurity, again, the ones I've highlighted in pink, I think it's just important to remember them off the top of your head. I've included some subsequent slides which go through a bit of the pathophys, but we won't get bogged down in that today because it's really not high yield, I would say. So we need to be concerned about temperature instability with the baby. There might be metabolic problems, things like osteopenia of prematurity. If anyone's been in the NICU or the special care unit, you'll see that that's something that's screened for, and extra minerals are given to the babies. Retinopathy of prematurity as well is another thing that's screened for. So that's actually something that occurs due to the resuscitation usually that we provide to the baby. And that's because you get all of this free radical damage from the oxygen that you're delivering 100% oxygen to the baby to try and resus them. And that free radical damage actually affects the retina because they're so fragile and the poor little babies. So that's a big one. And things like respiratory distress and issues related to like poor development of the lungs, a patent ductus arteriosus, whether if the baby's the transition from the fetal circulation to adult, or adult being the like out of the uterus, just oh my god, where are my words? Going from fetal circulation to like an adult circulation, meaning just a circulation that exists outside of the womb, that can sometimes not occur. And so we need to do things like administer indomethacin or ibuprofen to help promote that. And another big thing is neck, which can affect the baby's gut. So again, just remember a few of those, don't get too bogged down in it. These are some slides which have a flow chart and kind of go through the pathophys of those premature complications of prematurity. But in the interest of time, I think we'll just motor on for today. Any questions? Would you lower the O2 concentration for resus if the baby's prem to avoid eye damage, or it's best not to risk it? So the thinking is a baby with eye damage is better than a baby that's dead, essentially. Sorry to be crude. So unfortunately, we use resuscitation because we need it. We're not going to resus the baby if it's not necessary. So if the baby is unwell enough to require resuscitation, we're not going to compromise that in order to prevent a possible complication like retinopathy. So yeah, it is a balance of risks, but obviously a well and alive baby is better than the alternative. Cool. So now we're going to go over SGA and IGR, because I think that this is something that can often get a little bit muddled, at least it did for me. So SGA referring to small for gestational age, and IGR, which is intrauterine growth restriction. So it's important to remember with these terms that it's not something that we can determine based on the centile readings of a baby's growth. These are things that we need to look at the trends of growth over gestation to be able to determine which category the baby fits into. Because as we can see here, they're both referring to a baby that is less than the 10th centile. And if they're less than the 3rd centile, then it's a severe form of each. The difference being is that a small for gestational age baby is one that is constitutionally small. So they have an appropriately trending growth through over the gestation. It's just lower than the average. It's lower than what we would expect. It's less than the 10th centile, but they are still tracking and they still have a nice proportional growth over the gestation. This is usually something that is genetic, so it's more common in some ethnic groups. But the important thing here is that we, with monitoring, we see that there's no change in that trend. And we also will do things like Doppler studies to ensure that the distribution of circulation remains okay. And all of that indicates that the baby actually has no greater risk compared to a baby that is of the appropriate size. This is compared with IGR, which occurs because of a pathophysiological process in utero. So the baby may be tracking. It may be tracking low, or it may be tracking at a normal range, but then something's happened. There has been an insult that has occurred, and then there has been a drop in that growth. So it's really important to be able to distinguish the two, because we need to be able to determine the risk associated with it. And so for something like IGR, we will see changes in the circulation, and Dopplers can become abnormal. And obviously with that, we can infer that there's more of a risk to the baby. It's not a normal process that's gone on. So somebody has asked, I thought IGR can also be a sudden deceleration in the growth rate and doesn't strictly have to be less than the 10th centile. I believe that that's correct. But usually it is quite a significant drop. I don't know what the definition of a significant drop is, but yes, that is correct. You'll see, we'll do a question and you'll see that it's definitely like you're not getting that smooth growth projection. There's something that has caused a change. Oh, yes, Brendan, thank you. 2 centiles crossed is significant. That's exactly right. So let's do some practice now. We'll look at the first baby. So baby A, and we've got that light blue line that's trending. If somebody can write in the chat just directly to me, or let's do that. Tell me what can we say about this baby's growth? Cool. So, sorry, I haven't given you a lot of time, but we can see here, this black line at the top is the 90th centile, and this black line at the bottom is the 10th centile. So this baby A, the blue line, is tracking in an appropriate projection. It's got a good trend of growth, and it's just below the 90th centile. So this baby is good. They're appropriate for their gestational age. So we're not concerned about this baby. Baby B, however, how can we describe this baby's growth? Great. So this baby, we can assume that this baby was trending fine, but instead of following that trajectory of presumably like an 80th centile, it's now crossed and is around the 10th centile. So it's crossed multiple centiles and therefore is bad. It has suffered some sort of growth restriction, and we would call this an IUGR baby, correct? Then let's talk about baby C. Tell me what you think of him or her. Perfect. So that one was an easy one after we've gone through the others. This one has been tracking well. It's got a nice projection of its growth. However, it's just sitting below the 10th centile. So this is one that we would say is just small for gestational age, but there's no evidence of growth restriction because it follows that centile chart. Awesome. So important to know that a fetus that is IUGR has not reached its growth potential, and that's mainly because it's received an insult. These are a whole list of factors that can cause that, but the one that I want you to remember is placental insufficiency, because it is by far and away the most common. So that's all there is to say about that. And then in terms of the timing of an insult on the fetus, that actually affects whether or not the baby has symmetrical growth or asymmetrical growth. So this symmetrical IUGR baby correlates with this little description here. So if an insult occurs early in gestation, that is before 32 weeks, the baby has kind of global restriction to their growth, and so the head and the body, all parts of the baby, are symmetrically affected. The main causes of this are genetic disorders and torch infections, but symmetrical IUGR is actually less common than asymmetrical IUGR. Asymmetrical IGR occurs later, so after 32 weeks of age, and it's usually the one that's due to placental insufficiency. So it occurs later, the placenta's run out of steam, or there's been other things that are contributing to the placenta not being able to work. And because this occurs later, the baby has sufficiently grown in most areas that it has adapted to preferentially distribute the blood flow to the vital organs. So it goes to the brain, it also goes to the heart and the adrenals, but things like the kidney and other organs, kidneys and liver, are spared. So you get this baby that has a much larger head compared to the body. It's important to be able to identify that because, as I said, it leads us to being able to determine what the likely cause is. But also there are some different outcomes that result from whether or not it is a symmetrical or asymmetrical IGR fetus. So that was just kind of what I said in words. But what I want to know is, what do you think is worse, a symmetrical or asymmetrical IGR baby? Write to me in the chat and tell me what you think. Okay, so this is a really contentious question, and everybody it's tricky. So the worst one is actually a symmetrical IGR, because the baby has had that insult from early on, and it hasn't even grown enough to be able to adapt and preferentially distribute the blood to the organs it knows it needs. It's happened so early that the baby is just like, it doesn't even have that evolutionary capacity to be able to protect the organs that are most important. So symmetrical IEGR are worse off. Yeah. I've just included this more as a reference, not to go through, but I got really confused last year in women's and Paeds when we were talking about ultrasound monitoring throughout gestation. So I just included this. The boxes on the left here just show the different kind of tests that you can order, and then this is kind of what they are looking for or what they mean, and the parameters that we look for. So depending on the baby, you can look at prompt for like more specific guidelines. This probably is a bit more women's focused, but I just thought it was a good tool for you guys to have to refer back to. So for a SGA or an IEGR baby, what do we look at to try and determine when to deliver? So we track the baby with ultrasounds, particularly looking at Dopplers and things, and we assess the fetal's condition and the gestation that they're at, and then we balance the risk of fetal death to neonatal death. So we obviously want to be able to keep the baby in for as long as it's healthy for them and that they're still able to grow and get all of the nutrients that they need, because we can only do so much artificially in the NICU. But obviously we want to be able to ensure that the baby's not going to die in utero, versus if that risk is higher than the baby's risk outside of the womb, then we would need to deliver the baby. So if the IEGR is mild and uncomplicated and there's no changes to the Dopplers, then we can delay delivery until term. So that's really important, obviously, for things like lung maturation as a big one. Cool. So any questions on that? All right, let's whiz through the last two topics. We've got neonatal sepsis and neonatal jaundice to go, and these are two really important ones. The thing to take away from neonatal sepsis is we're talking about babies who are less than 28 days old, and because of that, the younger the baby that presents with sepsis, the less localizing the symptoms are going to be. So for a neonate, the main thing that we see is temperature instability, but we're not going to be able to say, the baby's like got a sore tummy or they've got a urine infection. We've got no idea at this point. They're just showing some general signs of being unwell. So any of those non-specific symptoms are things that we need to consider doing a septic screen for. Some key terms to think about are early onset sepsis versus late onset sepsis. So this is a bit tricky because some people define it less than 72 hours, some say 24 hours, 48. Essentially, the question's going to be pretty clear to you. And it's either going to be like the baby is 18 hours old or the baby's 5 days old. So if it's an early onset sepsis, the things that we need to consider is that the baby has contracted that infection through vertical transmission. So it's either commonly GBS, it might be E. coli, infections that they've contracted during delivery, or it may have been a congenital infection. And the reason that this is really important is because that there's a 10 to 30% mortality rate associated with early onset sepsis. Compared with this, a late onset sepsis, try and say that 5 times, is associated more with being in the hospital. So particularly NICU babies are at risk of this. So it's kind of like your hospital-acquired infection. And the benefit, or not really benefit, the thing with this is it's only a 5% mortality rate by comparison. Things that we want to know is, apart from the timing of the onset, is some maternal risk factors. So has the mum had choreo? Was the baby prem? What was the mum's GBS status? Did she get intrapartum antibiotics? Did she even get a swab? Do we know what her infection, her GBS status is? Has a previous baby had GBS in a previous pregnancy for that mum? And if they've had a prolonged rupture of membranes, that actually increases the risk by 10-fold. Then we want to know neonatal factors. So if the baby's small, are they premature? Have they had fetal tachycardia during delivery? Have they shown signs of stress like MEC-stained liquor, or if they had bad APGARs? So that's all kind of like the history that we're going to take. This here is a link to the neonatal sepsis calculator, and this is actually what's used on the wards. So you enter in all of these details, and it gives you an estimated risk of early onset sepsis. And then it tells you if the baby looks well, then the clinical recommendation is to do nothing and do vitals every 4 hours. If they're kind of, I'm not really sure, they're not super well, but they're not unwell, then they would advise to do empirical antibiotics and vitals as per NICU. And if they're showing signs of illness like temperature instability, for example, then again, trying antibiotics. So this is a cool little tool to play around with and just see what the different factors affect the result. But that's what they use on the wards to determine the baby's risk and their management. So I've just included this again as a reminder of features of an unwell child. So the things that we look at is the baby looking pink. Are they a bit pale? Do they have mottled skin? Are they active, or are they showing signs of being a bit slow and floppy? Are there signs of respiratory distress? Have they got deranged vitals? Have they got moist mucous membranes? And any other kind of signs of infection, which are also kind of difficult to see in babies. So just to refresh what a septic screen is. So it's 5 components. You've got your urinalysis that you send for MCNS, bloods, which include FBE, CRP, and sometimes ESR, blood cultures ×3, a chest x-ray, and a lumbar puncture. So for a neonate, we generally do the full septic screen, plus or minus the lumbar puncture, depending on how unwell the baby is. But the reason is we want to be able to try and localize the infection and therefore narrow down the management that we are giving. So rationalize our antibiotics mainly. So this is just generally for any baby that's febrile or showing signs of sepsis and their corrected age is less than 28 days. Then we have a high risk of a serious bacterial infection because they're immunologically naive, and congenital infections manifest within the first month. So we want to do full septic screen, admit them for empirical antis, and escalate it to a senior doctor because this is potentially bad. We talked about those mortality stats before. So the empirical antibiotics for any baby that's less than 2 months old. Sorry, I just want to interrupt here and say, I know this is really confusing because it's not strictly for neonates, but the empirical antibiotic range goes up to 2 months old. So anyway, it's obviously a baby that is greater than 1 month or greater than 28 days is not a neonate, but just to, I don't know if I've just confused anyone, but this is the empirical antibiotics for a baby that's less than 2 months old, irrespective of whether it's a neonate. So for early onset sepsis, we use Ben-Pen and Gent, and that's because our main concern is really GBS and E. coli. And then if it's a late onset sepsis, we actually change that to Fluclox and Gent. And we use cefotaxime if we don't know the status of the LP, or if it's a positive LP. We use cefotaxime instead of ceftriaxone because I can't remember the specifics, but there's a risk to the baby. They can't metabolize it or something like that. I can look it up and let you guys know. So cefotaxime for babies, small babies. Cool. That's just a whiz through neonatal sepsis. Now, thank you, Brendan. Ceftriaxone causes biliary sludge in 28. I'm glad you remembered something from the lecture I gave previously on this, because clearly I do not. Cool. When do you need ESR? Not sure, probably not ever. I don't know why it was in there. I just copied it from a previous slide that I had done, but it's usually just CRP, I believe. Sorry for that. Okay, let's go over neonatal jaundice now. So neonatal jaundice is something that affects 60% of all babies and 85% of all preterm babies. But most of the time it's physiological. So our risk factors are mainly preterm birth and congenital abnormalities. But we're going to go through it in 3 kind of stages. So we can break this down based on the timing of the presentation of neonatal jaundice, or you can talk about it in unconjugated versus conjugated. Quick refresher, unconjugated meaning that the liver hasn't processed it yet. So it's usually something that's like pre-liver or something affecting the liver when there's been a buildup of bilirubin that hasn't yet been processed, versus conjugated bilirubin that has passed through the liver, has been processed, but there's something post-hepatic that has affected it. So for the purposes of today, I'm going to talk about it based on the timing. So first off, we're going to talk about neonatal jaundice that presents in less than 24-hour-old babies. And this here is always pathological. So this is a nice little summary table from Muppets, and the ones that are highlighted in yellow are the most common causes. So we're just going to keep referring back to this table as we go through. So less than 24 hours, always pathological. It's bad. We need to bring attention to it. So for this, we think about the rule of 2s in terms of the causes of neonatal sepsis in the less than 24-hour-old baby. So the first one being sepsis. So we're thinking early onset sepsis, things we're concerned about are GBS and other congenitally acquired infections from the mum. And then the other thing to think about is hemolysis. And for hemolysis, there's also 2 causes, and for each of those 2 causes there are further 2 causes. So for extrinsic causes of hemolysis, this is usually due to ABO incompatibility or rhesus incompatibility, which, as we know, is more severe than ABO compatibility itself. And then we have intrinsic causes, so hereditary spherocytosis or G6PD deficiency. And in terms of how we would investigate these for early onset sepsis, as we said, we're going to think septic screen straight away. For extrinsic causes of hemolysis, we go for blood group and Coombs test, both for mum and bub, to be able to determine, if we don't already know, that there's an incompatibility there. And in terms of the intrinsic causes, we can do a blood film, but mainly the thing we want to know is just family history, because that can often give us a good hint. So that's all for pathological jaundice. Then we've got this 2-day to 2-week jaundice, and this here is usually physiological. Physiological meaning that it's just kind of innate to the baby. They have a lower activity of the enzyme that helps break down bilirubin, and there's also a few other factors like an increased turnover of red blood cells because they have a shorter lifespan in neonates. So there's an increased turnover, more bilirubin being produced, and the baby just doesn't have the activity of the enzyme that can keep up with that. So it's just normal. It's very normal, meaning that's why it's called physiological. And this occurs in a third of babies. Usually we see a gradual rise in the bilirubin, and it never really meets the treatment threshold. So it's just something to sit and watch. And mainly it's a diagnosis of exclusion, because we can see that the baby's otherwise well, they're afebrile, they're alert, they're not prem, they have normal wet nappies and bowel actions, and there's no other abnormalities like congenital, like chromosomal abnormalities, things like that. Some other causes of this jaundice is things like bruising. So if the baby has like a massive cephalhematoma, as the body is resorbing those red blood cells and breaking it down, that's increasing the amount of bilirubin that's being circulated in the system. And again, the liver can't keep up with processing that, so you get a presentation of jaundice. Sepsis is another thing that we need to think about, but again is much less likely after the 24-hour period. And things like breast milk or breastfeeding jaundice just happen based on the it's either factors in the breast milk or just the breastfeeding habits that can cause that kind of jaundice. But essentially, we're not worried about jaundice in this age group as much. Then we have prolonged jaundice, which is anything that lasts longer than 2 weeks. And classically, this is a structural issue. So a structural issue affecting the biliary tree most commonly. And so we get a presentation of increased conjugated bilirubin, as opposed to the other ones that generally cause an increased unconjugated bilirubin. So because it's structural, it's usually a surgical problem. And the two main ones to remember here are biliary atresia and choledochal cysts. So biliary atresia is where you literally get like a malformation or complete lack of formation of the biliary tree. And so that is commonly associated with the Algar syndrome, which is autosomal dominant and presents with this triad, versus choledochal cysts, which cause like a dilation of the biliary tree by comparison. So we distinguish these based on ultrasound mainly. So the biliary atresia shows a contracted or absent gallbladder, whereas the choledochal cysts have dilated biliary ducts on ultrasound. Someone has asked, could greater than 2 weeks jaundice also be breast milk jaundice? I'm not sure. I don't think it's classically one of the common ones that affects that that age group, but I'm not saying it's impossible either. I don't know. Sorry. So just go and RCH jaundice before 48 hours of age suggests hemolysis. Yeah, so that's one of the two. Sorry, I don't exactly know what the question is there, but the two big ones to consider there are sepsis or hemolysis in the less than 24-hour period. And there is a bit of a gray area because we've got our first group being less than 24 hours and our second group being from 2 days or 48 hours. So it classically presents in less than 24 hours, but it can be up to 48 hours. I'm not sure if that's the clarification there. Hopefully that makes sense. So why do we actually need to worry about neonatal jaundice? And that's mainly because unconjugated bilirubin is lipid soluble and toxic. And I'm sure everybody's aware of the fact that if it exceeds the binding capacity of albumin in the bloodstream, it can then cross the blood-brain barrier and deposit in neural tissue. And why did I delete the word? That is the big buzzword that everybody gets quizzed on at the hospital. Someone message me in the group chat, what is this deposition in the neural tissue referred to when we have increased unconjugated bilirubin? Yes, kernicterus. Everybody knows. Great. So kernicterus can cause a whole variety of things up to and including seizures, comas, and neonatal death. So it's bad. This is a baby here who is unfortunately suffering from kernicterus. So what do we do? Mainly, apart from the investigations we've talked about earlier to identify the cause, we want to monitor the serum bilirubin, and we can even do that by using a transcutaneous bilirubin, which is just like a probe that they check the baby's levels through the skin, and then we clarify it with the serum bilirubin because it's much more accurate. So this here is a graph that you would have probably seen on EMR if you've been exposed to babies with jaundice. And essentially from the days of birth, we plot the amount of serum bilirubin and we can look at where it sits on this line. If a baby has a serum bilirubin that sits down here, that's well below the phototherapy line, and we know that it's safe and we just continue to watch and wait. If a baby has a serum bilirubin that sits on the or above the blue line, then that is where we consider doing phototherapy. Sorry, there's lots of sad faces in the chat. I was trying to work out what was going on. Okay. Yeah. And if the serum bilirubin reaches the exchange transfusion level, then that's when we need to consider exchange transfusion as our treatment. But that rarely should happen, if ever happens, and then that's really bad and you got to go straight to the big guns. Another thing to remember is that there are different graphs based on the risk level of the baby. So premature babies have a lower graph because they're at higher risk. So we're a bit more conservative with them versus babies at term who we can be a little bit more lenient with. So what do we do? If they're below the line, we continue to monitor them. We watch and wait. If they reach the phototherapy threshold, then we use things like blue lights. So we've got our Billy lights or our Billy blankets, and the blue light helps to break down the bilirubin into a water-soluble state that can then be excreted. And complications of phototherapy are mainly benign apart from retinal damage. So that's why you see them with their cute little glasses on in their little solarium beds. An exchange transfusion is essentially, as the name suggests, you are exchanging the baby's blood with new blood to try and mop up and take out all of the unconjugated bilirubin and prevent it being able to cross the blood-brain barrier. This is super high risk though. So it's not commonly done, and it's bad if you have to actually get to that state. Hopefully we've intervened early enough. So I'm 2 minutes over. I'm sorry, Ash. But that concludes my presentation. If anybody has any questions, feel free to message me. You can get me on Facebook, or there's my email as well. Or yes, we might not open up to questions just now because we will motor on. But I hope that's been helpful.
Loved it. Good job, Mick.
Thanks, guys.